Hey Jessica, how are you?
Hi there.
Long time no see.
I know it's been a while.
Yeah,
Did you have a good holiday?
yeah, not bad.
It's good. If there ends up being any like operational questions or anything like that, and you guys need to tap me, um, happy to jump in. Otherwise, I'll just hang out and
I,
listen.
one of the questions I got in a text message was about when is our NICU resuscitation course um, available? Uh,
January 20th.
January 20th. All right.
Yep. So we sent out an email yesterday to all NRP advanced providers and instructors about a webinar that's coming up on the 26th.
Well, that
I
Um,
signed up for that.
great.
and 20th is when the modules will be
Correct.
live.
Yep. And then also after the 20th, like the instructors that are trained so far can start to create courses.
Perfect. Awesome.
I'm going to give everybody just another minute to get started.
No problem.
Hi, everybody. It's 2 after, so I think we're going to get started. I am really excited to be here today to talk a little bit about the new NRP changes with two fantastic members of the NRP Steering Committee. And I wanted to first introduce Dr. Kapadia. He is a neonatologist and associate professor at UT Southwestern Medical Center in Dallas. He completed his medical school in India before heading to pediatric residency in Chicago, and then completed his fellowship at UT Southwestern Medical Center. He is a liaison from the SOMPM on the NRP Steering Committee and on ILCOR. And we also have Dr. Anchan with us today. He is a neonatologist currently working at Brooke Army Medical Center in Fort Sam, Houston, Texas. He completed his medical school at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. He then completed his pediatric residency and neonatology fellowship at the San Antonio Uniformed Services Health Education Consortium in San Antonio, Texas. He is a current NRP Steering Committee early career member. Today, we are so excited to have you guys here to tell us more about these new changes coming to NRP, and how people can get involved in the NRP Steering Committee, or more involved in working with NRP, whether that's at their institution or their community. I personally am a NRP instructor mentor, so really excited to hear more from you guys. But again, thank you so much for being here today.
Thank you so much, Nicole. I'm going to go ahead and share my slides. All good?
Looks great. Go ahead.
Awesome. Okay. Thank you so much for inviting me to TECaN. This is a really exciting group and a very important group as far as future of neonatology is concerned. So I'm really excited to come to you all and talk a little bit about my favorite topic, which is neonatal resuscitation. So my charge was that we don't want to just hear about what changed. We want to understand why something changed. So my talk is going to predominantly focus on sort of what changed and why it changed, what is the science behind it. And then Josh will take over from me and we'll talk a little bit about how you guys can get involved in NRP and what are the resources available from NRP. And then time permits, we'll do some question and answers if you have any. Here we go. These are my disclosures. As Nicole mentioned, I've been with NRP Steering Committee for more than 10 years now. It's auto advancing, so I'm gonna see if it stops that. I've been with NRP Steering Committee for about more than 10 years. I'm immediate past chair, and right now I'm a liaison between the section of neonatal parental medicine and NRP. And it's exciting to talk to you guys about the ninth edition. I'm also part of the ELCOR neonatal content expert group, and some of the other disclosures that I have. I want to make sure that I say this, that the opinions that I'm going to express today are my own and they do not reflect the official view of NRP or ELCOR. So, when we talk about NRP, one of the things that I'm very proud of is that the NRP is evidence-based neonatal resuscitation education. Its mission is to develop and disseminate evidence-based neonatal resuscitation education. And its vision is to improve neonatal health by having an expert provider at every birth and an expert team at every resuscitation. So it's a very broad, ambitious vision. That's what drives NRP. One of the things that I wanted to point out is sometimes evidence-based medicine is not understood correctly. Many times, some people think that evidence-based medicine is all about randomized controlled trials and meta-analysis. But in my mind, what evidence-based medicine really is that you find the best evidence for the question that is in front of you or the patient that is in front of you. Many times in neonatal resuscitation, it's going to be a low quality evidence, at times observational study, at time an animal study, or some sort of a descriptive literature. You take that, you put your patients and patients' values and preferences together with your clinical expertise and come to a decision, which is in the hope that by using that decision, you will have the best possible outcome. And that is what evidence-based medicine is. The reason I wanted to start here is that you will see that some of the changes that we have made are based on multiple large randomized control trials, but some of the changes that we have made are based on observational studies or expert consensus opinions. With that in mind, let's dive into it. What has changed? And before even we do that, let's talk about how these guidelines come about. There are three layers that evidence sort of percolates through before it gets into our NRP textbook, right? So the first one is ILCOR. ILCOR is the International Liaison Committee on Resuscitation. This is a group of people who are not only from United States, but they are from Australia, New Zealand, Canada, Brazil, Japan, India, China. So these are a group of people from all over the world with different resuscitation councils get together. And throughout the year, they ask a question about where the science of resuscitation is. So they develop PICO questions, and then they conduct systematic reviews. Then they grade that evidence and then create this white paper, which is called the Consensus on Science with Treatment Recommendations. And this is where you have the state of the art science on what the science says. You take this white paper and then you put the North American patients' values and preferences in. Sometimes not all the questions are answered by ILCOR. Then this particular group, which is the Neural Resuscitation Guideline Writing Group, which from American Academy of Pediatrics and American Heart Association, and this group of people come together and they create the guidelines for our country, North America, United States, and this document comes about, which is your neonatal resuscitation guidelines. What NRP is, NRP is essentially the third layer, which is it is an education program. So you take these guidelines and then you put it in a way that those guidelines can be actually implemented at your hospitals. So that's where the textbook comes in. That's where the instructor toolkit comes in. That's where the different figures and videos and wall charts come in and the algorithms come in. So these are various tools and strategies to make sure that you have evidence-based neuroresuscitation program as an education program gets implemented at your hospital. You can train everyone so that when that baby is born and that baby needs resuscitation, you can perform optimal resuscitation and improve that baby's outcomes. So this is the whole process that it needs to go through before your guidelines are actually formed. Okay, so let's see what has changed. First thing, let's look at the algorithm. Has anything changed in the algorithm? The one thing I'll tell you upfront is that not a lot of things have changed in NRP 9th edition. So if you haven't implemented 9th edition changes yet, again, take a deep breath. There are not a lot of changes that have gone through, and once you are done listening to this presentation, hopefully that is clear. So what changes do we have in the algorithm? So in the algorithm, you will see that there are certain extra boxes that appear up here. So now birth is essentially an action item that you can see over here. You also have another box which is indicating the cord management plan. Now, the reason that cord management plan has been called out as a separate box is that we want to emphasize that umbilical cord management is really, really important for all the deliveries that are happening at your institution. You need to have cord management guideline in place so that you are not discussing the indications and contraindications and variations while the baby is being born. So hopefully you will have a guideline in place and you will follow that guideline when you are thinking about umbilical cord management. And again, touch base with your OBs before the delivery if possible to figure out what are we doing in this particular circumstance. The second thing which has changed is that you will see that we have tried to remove the word suction from this particular algorithm. The reason is that what we found is that a lot of people love using bulb suctions. Even worse, the suction catheters. If the baby is born and is making any sort of sound, we want to take that secretions out from the back of the throat. And that is absolutely not necessary. Large studies have shown that routinely suctioning is not really needed. We wanted to de-emphasize that. So it has been sort of removed from the initial steps routine suctioning. The third change that you will see is that we have removed from your target oxygen saturation table the 1 minute oxygen saturation, 60 to 65%. The reason is people were getting anxious that, hey, pulse ox is not picking up at 1 minute. At 1 minute, I'm supposed to be between 60 and 65%. What's happening? And many times, just the way the pulse oximeters are, you may not pick up that saturation. And in that case, rather than getting distracted, we want you to focus on actually taking care of the baby. So we have removed that 1 minute oxygen saturation from this table because many times teams do not actually achieve that. Okay. So then for the other changes, let's just think about a vignette, right? And think about in that way that what are the changes from the 8th edition to the 9th edition. So let's imagine it's Sunday, right? You're on a call at one of the hospitals that you don't usually round at. It's a community hospital, has a great coffee. So you go to the cafeteria and grab a coffee. Of course, at that time, you get called to a delivery as it happens. The call comes in, you go to OR5, you ask your 4 pre-birth questions, and you learn that it is a 32-week preterm IUGR baby with large VSD and Down syndrome who's getting delivered by a C-section for failure to progress after induction for preeclampsia. You go back to your team and start the pre-briefing, and then you are bombarded with questions. Hey, are we doing NRP 8th edition or 9th edition? Are we doing deferred cord clamping, cord milking, or are we going to clamp the cord here? RT asks you what concentration of oxygen you want to set up, what PIP, what PEEP, what rate should I bag the baby if the baby needs positive pressure ventilation. The nurse asks that, hey, what size of ET tube should I want to set up? And as you start thinking about these questions, you start wondering what sort of changes have happened between 8th edition and 9th edition to answer this question. As you are still thinking, because the coffee hasn't kicked in yet, right? So the brain is working a little bit slowly. You have babies being born. You take a deep breath because you remember that majority of these babies, they do okay, and you are expecting. Happy birthday. You're expecting this beautiful sound, but of course, because I'm giving you a presentation, that's not going to happen, right? So you're going to have a non-vigorous baby. Anyway, so based on that particular clinical vignette, let's talk about what changes between 8th edition and 9th edition. First question about the umbilical cord management. In 8th edition, we had said that for most vigorous preterm newborns, the current evidence suggests that clamping should be delayed for at least 30 to 60 seconds. And among the vigorous term newborns, the evidence suggests that a similar delay may be reasonable. So as you can see from the 8th edition language, we were hedging our bets. We were saying at least 30 to 60 seconds versus in 9th edition, what we have said is for most newborn infants who do not require immediate resuscitation, clamping the umbilical cord should be deferred for at least 60 seconds. So why the change from 30 to 60 to at least 60 seconds? Okay, so this, the next figure is not something new. You guys already know this, right? So benefits of deferred cord clamping, waiting at least 60 seconds allowed that placental transfusion. In term babies, it improves the blood count and hematological parameters. It enhances the iron stores, and it is recommended for most term babies where it is indicated. While in preterm infants, there is a definite reduction in mortality based on a large meta-analysis. There is decreased need for transfusions. There is improved hemodynamic stability with needing less inotropic support. And there's a little warning on the side, which is again was there even in the previous edition as well, that do not do cord milking in babies who are less than 28 weeks. We'll come back to cord milking. Let's focus on deferred cord clamping. So here I mentioned about the placental transfusion, but you and I both know that it's not just placental transfusion, is it? It is more than that. We know what happens. So let's focus here. So in a fetus, what happens is that the blood is coming back from placenta through the umbilical vein, and then it gets preferentially shunted through the right atrium to the left atrium and to the left ventricle, right? And the very little of that blood is going to the right ventricle. So if you look at the left ventricle here, majority of the preload of the left ventricle is coming from placenta. Now, because very little blood enters right ventricle, when the blood goes out, very little of that blood goes to the lungs, and very little of that blood returns back to the left ventricle. So again, in terms of preload, LV is totally dependent on this placenta, okay? Now, let's say this fetus is born and it's a newly born. That fetus has not started breathing yet. If baby has not started breathing yet and you immediately clamp the cord, what's going to happen is that this LV is going to have a loss of preload. So it's going to struggle with pushing the blood forward, and you're going to have a baby who is bradycardic, who is desatting, who is non-vigorous. Versus if you allow that baby to initiate and establish ventilation while attached to the cord, even for a few seconds, what will happen is that the pulmonary circulation will take over and LV will become less and less dependent on the placenta. And this happens pretty quickly. And then if you clamp the cord, then you do not, LV doesn't experience the type of shock that it can experience. So this is one of the hypotheses on why delayed cord clamping is beneficial. And it's not just placental transfusion, but something to do with the physiology as well. Okay, so let's go back to our main question on why this 60 seconds, okay? So there was a large meta-analysis done by Linne Seidler, and as you can see from 47 trials, about 6,000 premature babies, and it was a very well done meta-analysis. And what that meta-analysis essentially showed is it showed a dose response effect. What do I mean by that? So if you have your duration of cord clamping more than 15 seconds, less than 45 seconds, which is what they call short, medium duration up to 120 seconds, and then long duration more than 120 seconds. And they found that longer the duration of deferred cord clamping, greater the reduction in mortality. The greatest reduction in mortality happened when the cord was not clamped for 120 seconds or longer. So this was a very important study, created a lot of discussion. One of the things that ILCOR noticed is that in this particular study, even though it's a very well done meta-analysis, the number of extremely premature infants was very low. Out of the 6,000, only 121 babies were extremely premature. And also, they noticed that in some of these trials, the adherence to the long, when they decided that they want to do long delayed cord clamping more than 120 seconds, it was lower. Only 67% of time they actually did what they said that they would do, versus when it's short or medium, the compliance and adherence was much, much higher. So based on that, it was clear that 30 seconds doesn't seem enough, but do we really want to recommend 120 seconds and beyond or not? So what we ended up, ILCOR ended up doing is that ILCOR did another post hoc analysis. And in the post hoc analysis, they wanted to look at 60 seconds. And what they found is that newborns who received deferred cord clamping for at least 60 seconds, and this was like about 1,300 infants, they found that the odds of mortality was 0.63. So there was 37% reduction in odds of mortality. So clear benefit in preterm infants, along with the benefit in all the hematological things, improved blood health and transfusions, and so on and so forth. So this sort of gave ILCOR and AHA, AAP guidelines, and ultimately NRP confidence that, hey, we can go up to saying at least 60 seconds in terms of delayed cord clamping. And of course, there are other studies which also showed that similar thing in term babies also improves the iron stores and hematological indices. One of the things to keep in mind as you do longer duration delayed cord clamping, there is a risk, especially in the smallest of small babies, of increasing hypothermia. So you need to be very careful in your temperature monitoring, and you also need to come up with local quality improvement sort of strategies to prevent hypothermia when you are going for this longer delayed cord clamping. And again, remember, when we are talking about delayed cord clamping, we are saying when it's indicated, right? So if you have a non-vigorous baby, that's not what we are talking about in this particular slide. We are not talking about cases where the placental circulation is not intact. We are not talking about the conditions where maternal hemodynamic status is poor. So remember, only in indicated cases. Okay, going to the umbilical cord milking as a second question. So in umbilical cord milking, previously we had said that, less than 28 weeks, don't do it. Then Dr. Kapadia came up with multiple other studies and we were able to say a little bit more about it. So here we have divided it into 3 groups. This remains pretty similar to this recommendation that intact umbilical cord milking is not recommended for premature babies who are less than 28 weeks gestation because there is an increased risk of severe IVH. What about 28 to 34 and late preterm and term babies? We did not say anything in 8th edition. Now, what we are saying is that in late preterm and term babies, even though they are non-vigorous, that it's a reasonable alternative. And in non-vigorous preterm babies who are between 28 to 34 weeks, there is some evidence, but right now we are not confident enough to say, hey, do routine milking in all babies of that gestational age. And this comes about from these 3 main studies. One of the main studies by Dr. Kapadia, which showed that there is actually 3.7 times higher rate of severe IVH, and that is likely because of the fragile blood vessels, which I'll touch base on in just a minute. So this was not a new information. 8th edition also had mentioned it. Now talking about a couple of other studies in 28 to 32 weeks, there are many studies, actually 12 trials, including like about 1,000 babies, which shows some, if you do umbilical cord milking versus immediate cord clamping, there is some benefit in terms of hematological parameters and transfusions. But this is the one trial which Dr. Kapadia did, which is the largest study of about 1,000 infants, 28 to 32 weeks. And it showed that there was no increase in the severe IVH, because that is the main issue that we have. That what about 28 to 32 weekers or 34 weekers? Are they still at risk? So here it says in my slide safe, but I have sort of put a question mark on it. Is it a safe alternative? I do not know yet, but it's a pretty large study. It was designed as a non-inferiority trial. So even though it's 1.4% and 1.4%, when you look at the full 95% confidence interval, it goes from negative 1.4 to positive 1.4. So according to the statistical analysis, it did not meet the criteria of non-inferiority of 1%, which they had say in their methods and when they plan the study. So this is sort of a technicality, but that's what the study shows. What about non-vigorous term and late preterm babies? Again, Dr. Kapadia did a large randomized crossover study of more than 1,700 babies. And what he showed is that among non-vigorous infants of this gestational age, when you do the umbilical cord milking, they had lower rate of HIE, they had higher hemoglobin, they needed less cardiorespiratory support, they received less therapeutic hypothermia, but their primary outcome was NICU admissions. It did not show any difference in NICU admission, which was their primary outcome. And that definition of non-vigorous is also something you need to pay attention to. These are not necessarily babies who receive resuscitation. If the baby had pallor or did not breathe or had poor tone, any of those things, it was counted as a non-vigorous baby. But it's a very well done trial and it shows benefits. Okay, so why about this increase in IVH? When you do umbilical cord milking, what really happens is that when you do umbilical cord milking in a non-vigorous, especially in a preterm baby, what's going to happen is that you are increasing the umbilical venous milking, so you're increasing the LV preload. At the same time, your umbilical arterial milking is also happening, so there is increased pressure in the descending aorta, and this is all leading to increase in carotid flow. Combine that with the risk factors of chorioamnionitis and extreme prematurity. They have with fragile blood vessels. Now, with that, if you have increase in the carotid blood flow, what's going to happen is that you're going to have an increase in the intraventricular hemorrhage. So that is the reason that we are avoiding doing, we are recommending against doing umbilical cord milking in babies who are 28 weeks and less. Okay. So the next one is the oxygen concentration. Now, in oxygen concentration, previously, recommendations were simple. If you are late preterm baby, 21%, less than 35 week, 21% to 30%, low is better to start with, is what that 8th edition message was. In the 9th edition, things changed, and people are not very happy about it. And I will tell you why this came about, and then you can make your own judgment. So 35 weeks and above hasn't changed anything. This group got split into two groups, 32 to 34 weeker, and then less than 32 weeks. So this is the new recommendation where less than 32 weeks, NRP book says more than equal to 30%. So 30%, 40%, 60%, 80%, 90%, all of those things are in compliance with the NRP guideline. Now, why such a change? So starting with basics, this is not new. This we knew even in 8th edition time, that if your SATs are less than 80 at 5 minutes, it's associated with death and severe IVH. This was based on some of the studies that we did with Dr. Oi. It was an individual patient meta-analysis which showed this. Now, we don't know if it SATs of less than 80 at 5 minutes, is it because the baby is just sick and that's why there are worse outcomes? Or is it because we can actually modify it by changing how we titrate oxygen? We don't know. But it's a good idea to avoid SAT of less than 80 at 5 minutes. Okay. After that, James and Dr. Hoy and George and a lot of people got together and they did this network Bayesian meta-analysis with individual participant data called NetMotion. And in NetMotion study, they essentially divided into three groups. Low, which was 21 and 30%, then intermediate group, which was about 60%, and then high group, which was like 90 to 100%. And what they found, to everyone's surprise, is that when you put everything together, when you compare high group with the low group, 90 to 100% with 21 to 30%, there is some signal that high group actually had lower all-cause mortality. Although when you look at the 95% prediction interval, it sort of touches the line. And so this is a very fragile result. But when you're talking about all-cause mortality, you have to pay attention, right? So based on this, people started rethinking, is low really the way to go? And this is where I think the things started changing. So current NRP 8th edition guideline was low, then comparison with intermediate and high, and really NetMotion showed that there is actually possible reduction in mortality, and high may be favorable. We don't know really about intermediate. 60% oxygen, is that the good way to start? So this sort of created a lot of uncertainty. So remember, it's a very low or low quality evidence. This is not a return to like static 100% oxygen, but and there was no clear effect on other health issues. But when you see the effect on mortality, you pay attention, as I mentioned, and that's why the NRP guidelines now says that, hey, there is uncertainty of evidence more than equal to 30% is something you will have to use your own judgment in terms of your own institution, what initial FR do you want to use. But it's very important that you titrate up or down, pay attention to the oxygen, and that is equally important. And just to finish this thought, study that got published after the 9th edition came out is the Torpedo 30-60 study comparing 30% with 60%. Even though 60% when they initiated resuscitation with that, those babies had better oxygen saturations, less number of babies with less than 80% at 5 minutes. Still, when you look at the outcome of rate of death or brain injury or any of the important clinical outcome, it's no different between 30% and 60%. So even though there was some earlier oxygen-wise, there were some positives, outcomes are no different. So that's where we are with this evidence. Okay. So some of the other changes. Now, ventilation rate, rather than 40 to 60, and ninth edition says 30 to 60 breaths per minute. Why did we do that? Well, that is based on really low quality evidence, some observational studies, and I would encourage you to read those studies by yourself. One of the observational study showed that if your rate is around 30 beats per minute, it actually achieves the best lung aeration. You have highest expired carbon dioxide. And then another study, again an observational study, which showed that you get the highest tidal volume if rates are 30 to 40. If you're above 40, they are linked to actually lower tidal volumes. So the idea is to do 30 to 60. So we widen the range a bit and focuses on effectiveness, not just speed. And that's the reason for that particular change. PIP, there is a little bit of a difference on peak inflation pressure, the one pressure that you start with. Of course, you have to titrate as you go in certain babies, but in babies who are less than 32 weeks, you stay at 20 to 25 as the 8th edition said. But in 9th edition, we are saying that babies who are 32 weeks and above, your acceptable range is 25 to 30 as a starting PIP. And this is again based on some of these observational studies. So observational studies showed that linking the median PIP and volume. This particular study of 129 term babies showed that if you are at around 30 of median PIP, your tidal volume is close to 4.5 ml per kilo. There is this another study of term babies which showed median PIP of like close to 38, which shows tidal volume of about 5 ml per kilo. And then there is this multi-center trial comparison. What did you actually bag the baby at? With the TPs, and it showed that TPs can use lower pressures but still achieve the volumes that it can, right? So based on this observational studies, the idea is that in term baby, you can go a little bit higher as initial PIP, but don't go too high. You can actually cause trauma. This is more sort of, this change is more sort of expert opinion and sort of logical change. Remember our favorite Mr. SOPA, the ventilation corrective step acronym, or Mrs. OPA, depending on which side you are on. In 8th edition, we had said that you have to perform all the corrective steps sequentially in the same order, M, R, S, O, P. While in the 9th edition, we are saying that, hey, you may choose certain steps because certain steps have been proven to be more helpful than others. You can prioritize them depending on what you do. And we have broadened the interval a bit. We have given you a little bit more time in terms of um, um, uh, establishing effective ventilation. Endotracheal tube size, the numbers, weights a little bit different. It's a little bit more detailed now in terms of weight and what sort of endotracheal size you end up choosing. As you can see, less than 1 kilo has been split further, and 1 to 2 kilo also has been split a little bit. And this was sort of based on this particular study by Peebles et al. And this study was interesting because it was not necessarily a delivery room study, but what they found is that even in the NICU, based on the current NRP recommendation for certain specific weight groups, if you use the NRP table from the 8th edition, you had to downsize the AT tube more. And that weight group was like 1 kilo to 1.2 and 2 kilo to 2.2 kilo. And then, so now we have some, and if they use smaller tubes, they were rarely upsized. So based on this particular study, the table has been modified a bit. But remember, this study actually, when they were doing the study, the weight was known. Many times when we are in the delivery room, we don't know what the weight is, right? So we have to, again, wear the doctor's hat and use our judgment, but that's where this particular change comes from. This is again sort of change based on it just makes sense that where do you measure your endotracheal tube, that insertion depth is adjacent to the anterior edge of baby's upper gum line rather than baby's lip, which was in the 8th edition. So this is one of the other changes that we have seen. And then I'm just going to briefly mention this. You will have multiple webinars coming your way. You have multiple modules coming your way. In the NRP textbook, you will find, I think, chapter 15 and chapter 16, which are new, which have been added. 15 is about congenital heart disease. And this is something that people had requested, and we felt that it's the right time to add this to our book and try to think about what about babies with congenital heart disease. And as we know that many of these babies have congenital heart disease, and many of these babies have critical congenital heart disease. There are certain specific conditions. If you do not modify and from the standard care, then they don't receive the optimal resuscitation. So I'm not going to go through all the details, but it talks about various questions that you will ask if you are dealing with a cardiac baby in terms of, do you need to modify what you do in your standard NRP? Do we anticipate an unstable baby? There are only few conditions in which you would expect an unstable baby with a cardiac defect in the delivery room. Are there any additional features which make this baby unstable? If you have heart block, then you cannot really use the heart rate cutoff that NRP uses. If you're mixing lesions or in certain particular cases, maybe you need to modify the target saturations. You need to think about systemic blood flow and perfusion and whether prostaglandin should be ready and some additional equipment, medication, and personnel. So it teaches you in terms of how to take care of babies with this special condition, congenital heart disease. The last one, I'm going to breeze through this because you have a webinar coming up. And I think in chat, we can put that information where Anne and Taylor, we are going to talk to you in much more detail about this new course. And we have a chapter in the NRB book, Resuscitation in the NICU. It talks about the unique context. It talks about, NRP versus PALS and different pathologies that we have to deal with, like respiratory failure, but in the NICU, you are dealing with sometimes shock and arrhythmia and how to deal with them. And it also gives you some procedural guidance for certain specific procedures that are more common in NICU than in the delivery room. Of course, it's a unique context, right? The NICU babies, its focus is sort of acute decompensation, then the transition in the delivery room. And patients are often like already transitioned. They already have sometimes central access. CPR is much more common if the baby codes in NICU compared to in the delivery room. So it's a unique situation. NRP versus PALS, we can deal with this again in that webinar or in the Q&A, but I think it's a complex condition, and my answer is it's very difficult for me to imagine a single post-conceptional age beyond which PALS is better than NRP. You can think about etiology, you can think about systems, right? Like what kind of babies do you see in your hospital? What kind of providers you have? Do you have providers who are trained in NRP and PALS? Do you have your hospital as a small unit within a big adult hospital or a children's hospital? I think there are a lot of things you need to take into account when you are deciding between NRP and PALS. There are a few other tricks that this chapter will provide you in terms of thinking about acute respiratory compromise, and we all know this, but now this is officially part of this extra course, teaching you about DOPE, the displacement, obstruction, pneumothorax, equipment failure, the troubleshooting that you can do for an acute respiratory decompensation. I have to end the slide with a neographic from Satyan summarizing all the NRP 9th edition changes and maybe one or two more than what I had mentioned today. I'm breezing through because I want to give Josh a lot of chance to talk about NRP as well. Here are my references. I know they are very small font, but I'm happy to share these references with you all that you can read to prepare for NRP 9th edition implementation. And that's all for me. Thank you for listening. Appreciate it.
Okay, awesome.
Yeah.
Just stop sharing and let Josh share his slides.
Nicole, are you ready for me?
Yes, please go ahead.
Okay, I'm going to jump right in just for time purposes, but thank you so much, Vishal. That was awesome. I've listened to a lot of 9th edition update talks, and I think that was incredible. I haven't heard the evidence presented that well. So let me share. Can everyone see my slides? Okay.
It's good.
So
Yep, go ahead.
awesome. So as mentioned, thank you so much for the introduction. My name is Josh Anchan. I'm an Air Force neonatologist practicing in San Antonio, Texas. And I was given the less formal part of this talk, which is fine, but it is focused really on something that should be important to all of you listening to this, which is how can you be more involved with NRP even at early stages in your career? And so as we get started with this, I just had a few key points in case we have to cut short or you have to leave. But again, Vishal alluded to this, but the focus of NRP is delivery of educational content. That's the primary thing that NRP is focused on. NRP and the AAP really value a diverse range of professional backgrounds. And that's so that we can really develop the best educational curriculum, really, I think, in the world. And then finally, I hope everyone leaves here today feeling like that whatever work setting or whatever level of professional progress you are in, there are opportunities to not only be involved, but to innovate with NRP. And I'll talk a little bit about that kind of from a framework of how my career has gone and what led me to my involvement with the steering committee. So again, this slide should look a little bit familiar. Not going to talk too much about this, but we have ILCOR that really focuses on consensus of science guidelines that are internationally based. AHA and AAP then take those and write neonatal guidelines that are more focused in the United States. And then NRP is the educational delivery arm of that. So you might be feeling like, well, I'm a new neonatologist or I'm a fellow, and where do I fit into this? And so just one practical way that you can still be involved and be engaged with even what ILCOR is doing is that ILCOR does post their consensus of science and treatment recommendations on their website that I've listed, and they actually open that to public comment. So you can go on right now, and the most recent one is this initial vascular access for neonatal resuscitation. You can look at it, you can review it, and there may be situations where there is something practical component to what is being reviewed that you may have awareness of in your setting or have a question about or that requires clarification, that you can engage with them and potentially impact kind of what ultimately gets published. There may be things that the experts, so to speak, hadn't maybe considered or errors that you might be able to identify. So at any level, I think this is just an important thing to be aware of, just as a small way that you can be engaged even with what ILCOR is doing. They also published their guidelines in resuscitation and circulation to journals. And so if you have a passion for resuscitation, it may be worth kind of looking out for when those guidelines and what they're publishing, because that really can provide a clue to where resuscitation science is headed and maybe give you ideas of things that you may want to work on in terms of future research projects, different things like that. And then as far as NRP, so I wanted to kind of peel back the curtain a bit to kind of show you that we have a diverse range of backgrounds on the committee. So beyond the 2 chairs and the 8 committee members, they've recently added an early career member, which I currently hold. We have a community pediatrician member or nurse educator, but this group is not all, in the lab every day researchers running randomized controlled trials. There are that, and that is very valuable, but they also have a very diverse range of backgrounds because NRP values that in what they're trying to do. Vishal obviously is the section on neonatal perinatal medicine liaison, and so I think it's just important to recognize that he can be your voice if you have questions that are coming up in your work settings regarding NRP, or hey, this, I don't understand why we're doing this, or this wasn't communicated well. He's a great resource to reach out to, and also include my contact information at the end. So just realize that NRP wants to hear from really across the spectrum of its learners about how we can make this program better. Additionally, probably of a lot of interest to many of you, because I'm sure there are great candidates in the audience, my term as an early career member is ending this summer. So pretty soon, keep your eyes, ears, emails posted for updates from NRP, because they will be putting out a call for applications for the next early career member. So just an important plug. I included this slide just to say that NRP obviously very much values research experience and academic productivity. So if you are at centers where you're able to be involved with translational research and clinical research in the resuscitation space, or you're able to be involved in a scoping review related to resuscitation, that is wonderful. And that has huge impacts on NRP. But if you are also in places where you are focused on the education and teaching of NRP, simulation, developing assessment tools, how do we kind of get people to understand and master the skills better, quality improvement, those are also very highly valued in what NRP is trying to do, which is really bring the hard science into the practical spaces of the delivery room where real people are practicing them, and make it as best as we can. So we really value a wide range of what all of us should be able to be involved with. As far as my career path, so didn't realize I wanted to be a neonatologist. Actually, as an Air Force pediatrician, got stationed at a small community hospital. And that was actually my first engagement with NRP, and that was as an NRP instructor. And so it may seem very basic to everyone, and I hope that everybody on the call or watching is an NRP instructor, but that's not always the case among neonatologists. And so I would just say, I'm not going to go over the requirements to be that, but just realize that your experiences, even as an early career neonatologist, are very invaluable to the NRP learners. Think about kind of the changes in ACGME requirements, the pediatric residents that you might see who are NRP certified, but not necessarily people you would trust to independently lead a resuscitation. You can be a resource for those individuals when you're in their teaching classes to impart your learning and your wisdom onto them. Moving forward, so you may be an instructor, but are you a mentor? And so NRP has also tried to make this as easy as possible, where if you've taught at least 4 courses, then you're qualified and sort of automatically put into a bucket of instructor mentors. But are you actually operating in that? And so are you making yourself available to other instructor candidates to help guide them and mentor them? Because again, even as an early career neonatologist, you are going to have vastly more experience with newborn airways, with advanced resuscitations than most people. And so, it should be very evident to everybody that you have value to NRP in instructing and as a mentor. And so won't harp on that too much. As an instructor, I also wanted to make known the instructor toolkit. And so this is found on this website, the NRP Learning Platform, which I was an instructor for probably 3 years before I really had ever gone to this website. But it has an incredible wealth of information. So the NRP Lives have regular webinars that can be related to simulation, emerging science, and resuscitation. They just did one on the 9th edition updates. And so that is like, if you have, again, a passion for resuscitation, that is a place that you should be in your favorites and you should regularly go to see, hey, what's new? There are also tons of resources. The website was actually just recently redesigned to make it more intuitive. And so wanted to make sure everybody knows that that is available and we want people using that. In terms of quality research, so for me, my first assignment after fellowship, decided I wanted to be a neonatologist, went to fellowship, and then I got stationed at a small hospital, small NICU in Okinawa, Japan, that the military has for a number of reasons. And so that was a very eye-opening experience and may not be different than some of your experiences, but we had very inexperienced personnel, most with maybe less than 3 years of NRP experience. I think like 100 to 120 deliveries a month. So not a high volume center, and high turnover. So, turnover every 2 to 3 years is how frequently people were saying. And so there was a lot of just problems that we encountered. And so one of them was that our neonatal resuscitation equipment bag is what we had. It was locked because there was epinephrine in it. And so no one wanted to break the lock to ever open it, to like get out ET tube or supplies, like pre-prepare, look at the bag, because then it had to like go back down to pharmacy and they would have to re-inventory the whole thing. And when you opened it, it was like a complete disaster, and like stuff would fall out. And so just kind of on a practical level, we implemented some process improvement to change that system, not have it locked. People could go through it and make it more intuitive. And so on a very practical level, again, what problems do you see in your neonatal resuscitation environment, and what can you do to make them better? And so I don't exactly want to present this as a curriculum, as a, continuum, but for a lot of us, you're busy, you're new, maybe you're a private practice neonatologist, you may have a good idea, or you've heard about, hey, this is what NRP now recommends, we need to implement it, right? That's fine. But I hope, and I hope everyone doesn't feel like they have to be running multiple RCTs to make a difference with NRP. But all of us should be able to get to where we are doing more formal quality and process improvement, so we can actually measure what we're doing. So again, I don't have a lot of time, but are we having appropriate SMART goals? Are we looking at sort of systematically what are all the inputs that potentially could lead to the problems that we're seeing? And then what outcomes measures, what process measures are we looking at? And maybe most importantly, are there any balancing measures where we're making changes but then introducing new problems? So just kind of an emphasis on things that, I assume everyone on this call has a strong passion for NRP. As you have these ideas that are going to come up, thinking about how can we actually measure outcomes and do this in a way that is formal, measurable, and things that maybe you can actually even get credit for. Another thing I wanted to put a plug in for is the Drive network. So if you haven't heard about that, when we look at sort of, as you're thinking about quality and what you're doing and outcomes, what baseline are you comparing it to, right? And so we in the military don't necessarily have an opportunity right now to join this, but the idea is that any baby who gets CPAP or further, as far as a delivery room intervention, that data is collected from the member sites and goes into a data registry. And that's something that member hospitals sort of have benefits of being able to like partake in that data and share that data. That for many of you, if your hospital is not a member but has an opportunity to, I would strongly encourage you looking into that among your hospital administration, because for you individually, that could mean, potential involvement with various, national level research projects, and different things that can come out of this. But maybe most importantly, we've never looked at in this granular detail kind of like delivery room interventions and outcomes. And so to be a part of that, I think is a pretty incredible thing. So something to think about in terms of involvement. Other things we did. So we also recognized, again, problems that you might have is that people are certified in NRP and maybe even advanced, but they don't actually feel comfortable practicing resuscitations in the real world. And so we sort of implemented a curriculum where monthly we would go on day shifts and night shifts and catch people while they were at work, and just kind of cycle through people and, have a knowledge assessment that they would do, and kind of have an assessment of their simulation skills, get kind of an idea of like, how is this changing their confidence with resuscitation. We then sort of developed, before I even knew about RQI, sort of a quarterly curriculum, because the initial curriculum was just focused on kind of the initial steps in CPAP and ventilation. Well, can we kind of advance this and with our providers have everyone feel comfortable with what they need to do to prepare if a baby needs intubation, chest compressions, epinephrine, posted sort of information so people had access to various things, NRP videos, which by the way have been updated for 9th edition and are really phenomenal. So these are all little things that you may not think are important, but are very important kind of in your practical sites, and I think NRP does value. Currently, we're working on a mixed methods project with RQI, so sort of looking at kind of changes in ventilation effectiveness on a simulated mannequin, obviously among the learners that are enrolled, but also how does that translate to their actual lived experiences leading resuscitation, feeling comfortable with ventilation. Other thing I wanted to touch base on briefly is that as you have these different ideas, and they're going to come to you because you're all bright, young neonatologists, NRP has grants that they want to partner with you to help you kind of achieve some of these dreams and research ideas. So I'll highlight the human factors or education grant that is there, but there are many other ones. And so I'll let you look into that. And I know we're short on time. Other things. So I think we are in a ripe season right now with 9th edition just being released. And, Vishal did such a great job talking about all the evidence, but there are still so many questions that are not answered. I don't think my slides are really even going to touch on all of the questions, but with laryngeal masks, like we have now said, you can potentially use them as a primary interface. Well, how do we actually get delivery room personnel to do that? How long can we leave them in? If you put an LMA in the delivery room, are you going to leave it in if they still need it going to the NICU, or at what point does that get changed out? Will use it as a primary interface actually reduce NICU admissions? Cord milking. So we heard great evidence in terms of reduced HIE, but how do we get OB to actually adopt the practice? Do our real world outcomes kind of match the MINV trial in terms of that reduction in HIE in the term population? FiO2, torpedo results were just released, which Vishal alluded to. What are we actually using for oxygen? Still a lot of questions there. And questions that I've received a lot, and hopefully Vishal reassured you that 30 is appropriate for term babies. But with the starting PIPs, are we going to see more pneumothoraces? Are we going to reduce NICU admissions? Like, are we going to have more effective ventilation in the delivery room? These are all questions that are ripe for answering that you guys can all be on the forefront of. Other things, NRP via telehealth. You guys might work in settings where that is something you're doing. That is not something that NRP really has taken a strong stance on yet or has formal education on, but that's something that is very important, especially with kind of all the community centers and medical deserts. Other things that I'll just kind of list here, but again, just very important kind of areas that you can look into. The last thing I'll put a plug in for, and I know we're kind of slightly over time, is for me, I was also able to attend one of the NRP current issue seminars a few years ago. That is a really great place if you are really passionate about resuscitation science to hear from leaders in the field and also be able to interact, engage with members of the steering committee, hear their experiences, what they're working on. That this year is going to be October 2nd. I would really highly encourage you to try to make that. That's during APNCE. And then there, Bobby Byrne, who's the current co-chair, also has a neonatal resuscitation symposium in September. Again, phenomenal speaker lineup, very pertinent to active resuscitation topics. And so that is all I have. That's my email if you guys need it. Feel free to contact me if you have more questions about NRP or kind of role as the early career member. But thank you. And I know Vishal doesn't have a lot of time, but I wanted to leave some time for questions.
Wow, thank you guys so much. I think this was such a great discussion, not only talking about the practices and kind of the changes, because I do feel as the person who is kind of in charge and starting to get prepped for the changes, I think that there's a lot of questions about what is going to happen and why are these things happening. So going over the actual literature has been so helpful. And then it's also really great to learn about some things to do. I will say that we didn't get any questions, but one question that I had, just again, I am someone who is really getting these changes set. What do you think will be the biggest barrier or, the biggest part of these changes that might be the hardest sell?
Yeah, I think as you can see, many of these changes, they are not extensive in nature, but it depends on your institution for sure. I think one of the things that I have seen people struggle with a bit is the umbilical cord management. And even though umbilical cord management has been there in the 8th edition and now in 9th edition with much more nuanced and detailed recommendations, still the rate of deferred cord clamping is on the lower side. if you look at across the population. Umbilical cord milking, there are people who strongly support it. There are people who do not strongly support it. I think partnering with your OB colleagues and keeping them, when you're making those institutional guidelines. I think LMA is going to be really interesting. I am wondering how many institutions will actually end up using LMA as a primary interface. I'm already getting some text messages about places where it has gone well, places where it hasn't gone well. And one of the questions that comes up is that once I insert an LMA, what are my ventilation corrective steps, right? Because we have done face mask ventilation for so long that I think so there will be learning curve. There are a few things that we'll learn, and I'm really looking forward to one of the trials that Liz Foglia is leading, called Sugar Trial, which is a, I think, hybrid effective implementation trial looking at LMA practice just in general in United States, because majority of the evidence actually comes from outside US, where the practice setting is not similar to us sometimes. So yeah, those are the things that I identify. I do struggle. I personally, I mean, I've been part of LCOR, NRP guideline writing group, NRP steering committee, and at institution level implementation. I still struggle with some random cutoffs of 32 weeks versus 34 weeks. So those things I think will take a little bit of time to sink in. And I think that's where I think people like you, Nicole, are so important, where you actually give people time to actually learn well before you press the button of go live. Because the worst thing you can do is the confusion and chaos between 8th edition and 9th edition while you have a baby to resuscitate. So I think role such as yours, our instructors, is really, really important. And NRP is aware of that, and that's why we give you a long window before it has to be implemented.
Yes, absolutely. Thank you.
I don't know that I had much to add to that. I agree. LMA, I mean, I've had classes where I've sort of emphasized that. It's something I'm passionate about. We have RQI, so we've sort of, hey, look, this is much easier to ventilate, at least the mannequin, right? And now I've used it. I was saying this for a while. I had never used it on a baby, and used it. It worked very well. But the residents, I'll teach them, and then we'll go into the living room, and they still won't really even look for have an LMA ready. I'm like, didn't we just go over this? And especially I mean, they don't have any experience intubating, so I'm like, it seems like if I was in your situation, I'd be even more inclined to have it. I think it's going to be kind of we've changed our delivery room checklist to put that much higher. So it's even above mask is kind of the goal. And so that's something they just always have and know that they have, and then they can move on to the other things. But people are going to have to be creative, and I'm really curious kind of again what everyone comes up with in terms of educational implementation.
Yeah, that's awesome. It'll be really, really exciting to see what happens next. I had just had one more question, and then we'll finish up. But how long does it take to go from these, international statements to the NRP changes? Some of those studies that you showed were older, and some of them were a little bit newer. But how long does that take usually?
A great question. It's such a complicated thing to actually have an international group create the consensus of science, but you can't really wait for consensus of science to be released and then start working on your guidelines. So you have to simultaneously start working on your guidelines. And as you are starting to work on your guidelines, you can't just wait till to write the textbook. So you have to continue. So it's a ever evolving process. I think one of the things that I think the AAP has been very smart about is that you have people who are common between these three groups, and then there are liaisons sitting on different committees. So all these sort of work simultaneously together. One thing, so that's one aspect. It's complicated, but I think now all the groups are trying to do the updates, annual updates, and then at 5 years we have this big sort of guideline come about. But I think one of the questions that you raised about the older studies versus newer studies, that's also equally important. I think systematic reviews do take time. I think the goal is at the ILCO level to be more efficient. And I think within a year, they do a lot of PICO and they update a lot of PICO. So I think all these three groups are very aware. Whenever the threshold, whenever something crosses a threshold where you need to implement that change, I think you see an urgency amongst that group. But sometimes some of these studies, even though they are great and they are saying something, it doesn't really cross that threshold where it will actually change your practice. And that's why I think it sort of takes time for them to percolate through. Enough studies get together, you do a meta-analysis, and boom, now you have the effect size.
It's wild as the early career member, just watching the work take shape among kind of all these such experience kind of in the room. But it's very interesting because you don't want to release anything that's inaccurate. If there's newer studies that maybe haven't reviewed, like, well, you don't want to ignore that and then have to wait a whole nother 5 years before you can put that in. And so everything I think is there's a lot of review and a lot of discussion about like, how do we toe that line of like following this process, not just, creating our own thing, but still being forward facing and utilizing the best literature that we have. So.
Yeah, I think one thing I would add is that, um, I mean, these people don't take evidence and grading lightly. I've sat on Alcor meetings where we have discussed one sentence for more than an hour. So all the things that are coming across are really, really very well reviewed and thought of. Um, and I'm really proud of my colleagues doing amazing work.
That's awesome. Yeah. I think that also a little bit highlights how we just need more evidence. How are we going to get better evidence so we can have more than that low quality? But that also takes time. That also takes money that, takes a lot of buy-in too. So it's a challenge. But I want to thank you guys again so much for joining us today and for everybody attending. We will be placing this recording on our TECaN YouTube channel. But again, please reach out if you have any questions. Thanks again for joining us today. Hope everybody has a great day.
Thank you.